discussion, Sleep and Aging, Research and Treatment Implications. My name is Elizabeth Gallick. I'm a nurse practitioner, professor, and chair at the University of Maryland School of Nursing. I'm also a fellow of the GSA and a past president of the Gerontologic Advanced Practice Nurses Association. I'm really excited to be your host for this momentum discussion. Sleep, like nutrition and exercise, is a key determinant of health and well-being. Sleep is a basic human requirement that affects endocrine, metabolic, neurological, and cognitive function that are critical to health. Many adults find that they have difficulty sleeping a healthy amount. In fact, according to the National Sleep Foundation, symptoms of insomnia have been reported in up to 50% of older adults. However, insomnia diagnosis and treatment is under 5%. The impact of disturbed sleep on health and well-being is under-recognized, and chronic insomnia is underdiagnosed and undertreated. And this can lead to increased healthcare utilization and expenditures. This is a third in a series of addressing sleep disturbances. The other programs include a webinar called Chronic Insomnia in Older Adults, Epidemiology and Approaches to the Assessment in Primary Care Setting, and a podcast, Successful Conversations with Older Adults About Sleep Disturbances. Both of these are found on the GSA website. I'm very pleased to be speaking today with several experts and friends, experts in sleep disorders. First, Dr. Christopher Kaufman, who is an assistant professor in the Department of Health Outcomes and Biomedical Informatics at the University of Florida College of Medicine. Next, we have Dr. Adam Spira, who's a professor and vice chair for research and faculty in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. We also have Dr. Katie Stone, professor in epidemiology and biostatistics at the University of California, San Francisco, where she's a senior scientist at the California Pacific Medical Center Research Institute. And last, but certainly not least, Dr. Michael Vitiello, professor of psychiatry and behavioral sciences at the University of Washington, Seattle. This program was co-developed with the Gerontological Advanced Practice Nurses Association, also called GAPNA, and has received support from the Eisai Pharmaceuticals. So let's go ahead and get started. So, wonderful and esteemed panel. We often have to tease out from the older patient that that patient is experiencing sleep disturbances. Why are sleep complaints so common in later life?
Well, I'll lead off with that. First, you mentioned that about 50% of older adults tend to complain of significant sleep problems. And that's true, but I do want to state a disclaimer before we get too deeply into sleep problems. And that's, we also need to recognize that about half that population doesn't complain. So it's not necessarily that being old means you're going to sleep poorly. That's a message you're going to hear me repeat several times today. Nonetheless, yes, there's a lot of reasons for sleep quality to go down with age, and let's talk about that and open it up a little bit. If you were to look at the overall changes that occur in the older population with sleep, older adults sleep less. They sleep in a more fragmented fashion. That is, there's more nighttime wakefulness. They sleep more lightly. That is, you don't have as much deep sleep. And very often their sleep may change in terms of its timing and occur a bit earlier at night, going to bed earlier, waking up earlier, and sometimes waking up too early. So those are the principal sleep changes that occur, and we see that in the general population. But if you look at the causes for why those occur, there are many, many causes. I've already suggested to you that aging is probably not one of the major causes. We have a lot of reason to suspect that it's a lot of the things that occur with aging, the illnesses, lack of activity, medications and treatments for illnesses, that all may be responsible for a lot of the changes in sleep that we see. And in fact, when we look at a very healthy, carefully screened population, we don't see as much change in sleep. And it suggests that if you stay healthy, your sleep remains pretty sound. But that doesn't mean that if someone has a complaint that it's not real and that it's not problematic. The reasons, it's important for us to figure out how that's being caused. So whether it's a sleep disorder like sleep apnea, or a real insomnia, or a comorbid illnesses that's contributing to sleep, we need to parse those out. And again, at the bottom of that, we need to recognize that growing old doesn't mean sleeping poorly, and that most sleep disturbances we see in older adults can be treated and are worthy of treatment.
Thanks for sharing that. I know.
If I may jump in there just for a moment, one of the things that we should talk about that I don't think Michael mentioned yet, but of course he's aware of, is various psychosocial changes that occur with aging that may contribute in part to these to the relatively high prevalence that we've discussed. And those changes can range from things like retirement, in which one has potentially a restructuring of one's day with plenty of people. I always like to say when I'm giving a talk, plenty of people who retire end up having a very, very busy schedule. Others do not, and that can lead to inactivity, which, as Michael said, can lead to sleep disturbance. Could lead to opportunities for napping, which many of us would like more of, perhaps, but can also be detrimental to sleep if left unchecked, or if it happens too much. So retirement is one. Another one that's important to consider is caregiving. There's a sizable population, as people watching this probably are aware, of family caregivers who are responsible for the well-being, the care of their family members, and that can be associated with nighttime sleep disruption and with stress potentially that can further worsen sleep. And the other one that I like to point out is bereavement, which is something that becomes unfortunately more common as we get older, as we are faced with more losses socially. Due to passing away of loved ones. So all of those things can potentially lead to sleep disturbances, as well as all of the biological factors that were mentioned previously.
Yeah, Adam's quite right. And just to amplify on that, it's not just the psychosocial aspects, but as he's already mentioned, some of the behavioral things that happen. A lot of how we act during the day impacts our sleep at night, and that can either be for good or for bad. You can make a person's sleep terrible just by bed resting them, for example, if they're just stuck in bed too long. Our sleep environment, temperature, light, comfort of mattress can also have impact. And these are things that people don't necessarily think about, but that can often be a simple, easily treatable problem that can then improve their sleep. Perhaps not bring it back to 100% of what they'd like, but can have significant impact, even if you're not going to a practitioner.
I could also chime in and add that sometimes activity patterns during the day can impact nighttime sleep, and managing things like naps later in the afternoon, or getting some morning exercise and exposure to daylight can really have positive benefits in terms of sleep.
I think in the past year and a half or so, with the pandemic, with people's activities patterns really changing, we've probably seen an uptick in sleep complaints. Thanks for sharing that. What about the impact of medications? We know that older adults take a variety of medications. Can any of them impact sleep?
Oh, certainly. Even a simple thing like what used to be called a water pill that many people take for hypertension. If it's taken at the wrong time of day, like in the evening, as an example, it might increase the likelihood of uresis, of bedtime, your need to urinate, of nocturia. Similarly, cardiovascular drugs that are given to support cardiovascular illnesses very often can impact sleep, and not necessarily just make it worse or disturb it, but make you unnecessarily sleepy. So the other thing can also occur. Both of those impacts can have significant detriment to a person's normal sleep behavior. And that's something to always be conscious of. If you read the contraindications for drugs that are commonly given, and most older adults, the average older adult has 3 chronic medications or more that they're taking. Almost inevitably, it's going to impact sleep, either making it worse or making it better in the side effects. And so it's important, if you're one of those people that get hit by that, to discuss it with your practitioner, because they can sometimes adjust dose or timing or go to another formulation to mitigate the nature of the impact.
Thanks for that. Also, there are some antidepressants that might be a little stimulating, that if it's taken too close to bedtime, it can interrupt sleep as well.
Yeah,
So,
I was going to comment. I'm sorry. I was
No,
going to
go
comment
ahead.
upon that with the use of other psychotropic medications. They can either, as you mentioned, they can either cause awakening during the night, but they could also provide quite a bit of sedation during the day, which also could affect sleep. And when there's a combination of that with other substances such as alcohol and various other daytime substances, it could have a pretty drastic impact on one's sleep.
good point. As we get around the winter holiday time, we're probably going to be seeing more alcohol use with our older adults as well. So what are some of the implications of sleep disturbances on older adults? How does it impact them?
I can comment a bit on that. So in addition to just impacting quality of life and daytime function, there can be downstream effects of poor sleep, such as an increased risk of falls. And those effects are known to be independent of some of the medications that people use at night to treat their sleep, which can also impact risk of falls. So these are definitely concerns with treating sleep problems. That's one of the main outcomes that my research has been focused on, and I'm sure others can comment on other downstream effects.
Well, there are the immediate effects that we're usually aware of. That is, next day we feel tired, perhaps hazy thinking, perhaps our affect is a little affected, we're grumpy. Those are the types of things we think of in terms of short-term impact. But the interesting thing, and what's emerged in the literature over the last 10 or 15 years, is that really quality of sleep has a profound impact on our health in general. And what I mean by that is sleep disturbances, either an insomnia, sleep apnea, a variety of the other sleep disorders that can make sleep worse, tend to have impact beyond simply disturbed sleep. That is, they may put us at risk for other illnesses, be they psychiatric illnesses like depression or cardiovascular illness, cerebrovascular illness. There's good evidence to suggest that disturbed sleep long-term can put you at risk for developing diabetes. And very exciting area of literature now is showing that there's a good evidence to suggest that disturbed sleep may have impact in terms of dementing disorders and developing Alzheimer's disease. Now, we're focusing on the elderly now, but this is important to know generally, because the earlier you start to improve sleep, the less risk you will be of these other disorders. So it's not just that sleep is a symptom of illnesses. Very often sleep is contributory to illness. And that's, again, something that's become very clear in the last 10 years and really puts the goal of sleep health very high in the public eye. Yeah,
I would just like to chime in and say, that's really a big shift it really is a stark change. If you think about how people thought about sleep, it really seemed to be the thing that was affected by the other bad stuff. But really, it's the last 10 years or so, as Michael said, Alzheimer's disease is a great example, where when you talked about sleep and Alzheimer's disease, people would go, their thoughts, if they were researchers or clinicians, would often go to the significant sleep disturbance that you see in people with, Alzheimer's disease clinically. But a range of studies, from observational studies in humans and studies in animals, now show us that it's quite plausible that there is and there's not much doubt that sleep disturbance likely accelerates, or we don't know exactly whether it accelerates or sets the stage for, but it plays a causal role in the development of Alzheimer's disease, we believe.
I think that'll be some new information for some members of our audience. Thank you for that, Dr. Spira. So there are times when a referral to a sleep specialist is merited. However, how can our older adult patients be treated while a referral is being determined or scheduled or pending? And what are the goals of treatment for sleep disturbances?
Well, let me answer your second question first.
Okay.
The goals of treatment are to, if not cure, at least ameliorate the impact of the particular sleep disturbance. And what that likely illness is, what that likely sleep disorder is going to dictate course of treatment and time to treatment and time to an effective referral. So I'm working backwards. So while that is in process, if you as a practitioner are working with an older adult and you decide that, gee, maybe they have a chronic insomnia, I'm not ready to treat it, but I know I can refer them to a sleep clinic where they can be treated, there are things you can still do. Similarly, you could do those same things even if they're suspected of having sleep apnea or restless legs or a variety of sleep disorders. And we've already talked about that to some degree, and that is the habits that people have around their sleep, what they do to make their sleep better, worse. We used to call it sleep hygiene, we now call it sleep habits, and it's very reasonable to refer to, before referral, to go through those sleep habits with an individual and try and get them to maximize those habits, to maximize the quality of their sleep. And there are a lot of aids to that, little spreadsheets that one can find from various sleep-related organizations that are available that can facilitate a practitioner doing that kind of intervention.
I'd like to add a little bit in terms of the goals of treatment, because I think, clearly the primary goal is to address the sleep complaints. And those may have a range of different causes, and the nature of the complaint may differ from person to person. But also there are different sort of patient-centered outcomes that are related to poor sleep that we should be focused on as well. And those can include things like pain, like mood, and fear of falling or increased risk of falling. So it's really important to understand what motivates patients to come and bring these concerns to their providers. And those outcomes are very important to patients as well, and should be factored in as sort of goals of the treatment, is to ameliorate those concerns as well.
Thanks, Dr. Stone. So we'll move on to talking more about treatment now with behavioral and cognitive therapies. Basically, what are they for people who may not be familiar with them? And if you could share with us from your experience some of the benefits and some of the concerns of using these types of therapies with older adults.
Well, before we move on to that, I'd like to make one, I think, important distinction in terms of treating. Let's talk about insomnia, because that's the most common complaint and the common sleep disorder in older adults. The big separator in terms of how we choose to treat insomnia is time course. That is the insomnia chronic? Has it been around a long time? Or is it new, emergent, transient, or situational? Very different treatment approaches depending on that. Pharmacotherapy tends to be most appropriate for short-term or transient insomnia. And then the cognitive behavioral approaches that we're going to talk about are now recognized as the gold standard for chronic insomnia. And when I'm talking about chronic insomnia, I'm talking about insomnia that's around for months, years, as opposed to transient, which is days or weeks.
And one thing that I'd like to add is that sometimes there's some confusion between these well-established efficacious methods such as behavior therapy or cognitive behavior therapy for insomnia and other sorts of less intensive interventions such as the sleep habits or sleep hygiene recommendations that Dr. Vitiello talked about. And if you're talking about, and there will sometimes be, those sleep habits are often a component, changing those sleep habits might be a component of those other therapies, behavior therapy, cognitive behavioral therapy for insomnia. But they are, when it comes to a chronic insomnia, they will not on their own do the job. They are necessary but not sufficient to lead to an improvement in insomnia. Just wanted to make that point.
How quickly does cognitive behavioral therapies work for sleep disturbances for individuals with chronic insomnia? Is it a quick fix, or might it take a little longer time?
Well, they've found that these behavioral therapies, take a little bit longer to become beneficial for patients, but but they're much more, their treatment effect is much more long-standing than medications, for example.
In terms of the length of treatment for cognitive behavioral therapy, standard classic CBTI, cognitive behavioral therapy for insomnia, typically is given over a course of weeks, usually 5 to 8. And that's usually with maybe a half an hour to an hour session. So you can see benefits within the first couple of weeks. But for it to work long term, it's best to run the full course the way Chris just described. I will say, though, that there is another type of therapy that utilizes the same principles. It's called brief behavioral therapy for insomnia. And that is done in either 1 or 2 sessions and can be done very quickly and has reasonable efficacy even in the short term, and with long-term follow-up as well. So that hasn't gotten as much play as it could. And I think as we continue to advance in terms of our treatment of insomnia, we may see more of that. And indeed, people look for more effective ways to bring CBTI out of the academy and into treatment. And we'll probably get back to that later when we talk about some promising things in the future.
So could you tell us a little bit more in terms of some of the research about CBTI? Has it proved to be highly efficacious, or are results more mixed?
CBTI is remarkably efficacious. The results are consistently positive. There have been a number of what are called meta-analyses where all the studies of a particular treatment are looked at and clustered in such a way to examine the treatment effects overall. CBTI consistently, whether in uncomplicated insomnia, that is in healthy people that only have insomnia on their hands, or in comorbid insomnia where there are other illnesses on board and it's a more complex problem. Regardless of that, it's been consistently shown to be very efficacious. Works for about 2/3 of people on average. It works in terms of improving both the time to fall asleep, the time to stay asleep, and reduce nighttime wakefulness. And in terms of people's reported sleep quality, the findings are very, very significant. There were some old studies now, they're out of date, but that showed that early cognitive behavioral therapy in the short term was at least as efficacious as medications were. So in answer to your question, it is a very effective therapy, and it was recognized finally about 5 years ago now by the American College of Physicians as the first-line treatment for chronic insomnia.
That's great information to know.
Oh, sorry to interrupt, but one thing I would say is that, you know, these treatments are very highly efficacious, but there's a problem with access to them, and we'll get into that in the later part of the webinar. But you know, these treatments are not necessarily available, and there's a number of innovative delivery modalities that, again, we will talk about later.
Great. So let's
something else, if I can chime in, something else that's been coming out of the Cbti literature, for example, cognitive behavioral therapy for insomnia, is there was a recent study, just as an example, popped to mind, showing that from Michael Irwin's group, showing that in people with insomnia, older adults with insomnia, in fact, Cbti prevented new or incident depression and recurrence of depression, which is a pretty fascinating finding. I wanted to just mention. So not only is it effective in older people in preventing or in treating insomnia, but it can also have these other effects.
Adam raises a very good point, and it's not, that's hot off the press. That finding was in November. But there have been a number of studies previously that have supported that, but that have also shown that if you've successfully improved sleep, you can often improve the comorbid illness, not just depression, but in other comorbid illnesses, pain syndromes, for example. There are secondary gains to improving your sleep well beyond just improving sleep. I did want to say one thing, though. We keep talking about Cbti, and the audience may not know what that animal is, so maybe we should just briefly describe it. Cognitive behavioral therapy is a multimodal therapy. It has a number of components. It's not necessarily the same for everybody in terms of both the practitioner applying it or in terms of the patient receiving it, because there are some things that you can tweak. But in general, that it consists of the following components. There is a sleep education component. There is a review of sleep habits to it. You use a behavioral sleep log throughout it, so you're logging your sleep and your wake patterns to see how they may change over time. And then there are a number of things one does in terms of therapy directly to impact falling asleep, and that's something called stimulus control therapy, where you're effectively learning that the bedroom predicts sleep. It doesn't predict anxiety. It doesn't predict eating pizza. It doesn't predict a lot of the negative things that people can do in the bedroom environment, which doesn't help their sleep. It also teaches them to restrict their sleep, to shorten their bedtime, to better meet their sleep need, because a lot of times one of the things that insomniacs do is they say, I don't sleep well, so I should try and sleep more. You spend more time in bed, and it actually diffuses their sleep drive and makes their sleep worse. So that you train them to tighten their time in bed so that their sleep is more intense, more concentrated. And so those two behavioral approaches really maximize sleep quality and take advantage of how sleep is, if you will, maintained by the body's natural sleep drive. In addition, you can include relaxation therapies because a lot of times people have busy brain, wake up in the middle of the night, think about all kinds of terrible things, and you got to teach them not to do that because it doesn't help their sleep. And then there's also a cognitive component where people basically examine their beliefs and conceptualizations of sleep and come to recognize that, yes, their sleep may be compromised, but they're not going to die of lack of sleep, that their sleep is somewhat under their control. And that package as a whole, as I said, is remarkably effective. And that's cognitive behavioral therapy for insomnia in a nutshell.
Thank you, Dr. Vitiello. That summary was really helpful, I think, in framing that non-pharmacologic intervention. So now we're going to switch and move over to pharmacologic therapies. So what are some of the options and what are some of the benefits and concerns for using medications with older adults with sleep disturbance or chronic insomnia or short-term insomnia?
Well, I can comment upon that. So there are a number of pharmacological options available. One is FDA-approved medications for sleep disorders. So these include a variety of medications, including the Z drugs, which are zolpidem, xalapine, and azopiclone. So there are also a number of other medications used off-label that are also shown to help improve sleep. That one of major example is trazodone, which is a atypical antidepressant that is shown to be quite safe actually when used for sleep disturbances. There are also a number of over-the-counter medications and also herbal remedies such as melatonin that, again, have shown to work in various patients. But when making considerations about use of these various options, there's a number of risk and benefits that need to be accounted for. It should be noted that OTC medications and melatonin, haven't been fully assessed in terms of their safety, but so more research is needed in that. But something that's kind of important, as Dr. Vitiello had mentioned, that you kind of got to think of two things. So number one, is it short-term problems with insomnia and sleep disturbances, or are they long-term? So, in terms of short-term transient insomnia symptoms, medications are actually quite effective. And you kind of have to tailor the various medications to the type of sleep problem. So, for example, are you trouble falling asleep? You might want to have a short-acting medication. If you have trouble staying asleep, you might want a longer, another medication. They're not without their risk. There are concerns about falls and hip fractures from use of these medications, particularly when used among more vulnerable older adult populations. But I think when you think about long term, the behavioral approaches are much more appropriate. And notably, the American College of Physicians most recently recommended the Cbti be used as a first-line treatment for chronic insomnia, and that medication should only be added if and only if Cbti, for example, was alone ineffective.
I could add that also there are still some gaps in evidence as far as how these treatments compare to each other, not only in terms of improving sleep in particular patients, but how they affect other outcomes. So these are some gaps that still need to be addressed. For example, they may have very different profiles in terms of the safety outcomes that really haven't been comprehensively studied in sort of head-to-head comparisons. So I think maybe get to that a little bit more in research priorities, but I just wanted to chime in with that.
Yeah, that's a very, very good point. In terms of pharmacotherapy, the new kid on the block, which are the orexin receptor antagonists, are very promising. One of the things that we've seen in pharmacotherapy for insomnia is we've gotten better and better over time. We've gone from terrible to bad to okay, and now we may be moving into, gee, this might be not bad. It's been a long trip, but that's effectively what's happened. The drugs have become less side effect and more reasonable effect. And now we're moving towards a drug, and this is in the last 5 years or so, that works in a totally different way from previous sedative drugs, which have been sleep inducing. This is sleep permitting. It actually suppresses the wake drive your brain has. And it's probably just fine for short-term insomnia. But as Dr. Stone indicated, the jury is still out in terms of long-term efficacy. And I don't believe there's enough data yet where the FDA has approved it for long-term treatment.
I think with the medications, having results that happen fairly quickly in terms of sleep is something that, may drive older adults to have discussions with you about pharmacologic interventions as well. Okay, so now we're on to some exciting stuff, emerging therapies and research. So what emerging therapies are on the horizon in terms of sleep disturbance?
Well, I did speak to one as we were coming to the end of our discussion of insomnia, and that is the orexin-based compounds. They work in a very different way. Their side effect profile is quite safe. For example, there's no respiratory depression, which was a risk even with the Z drugs. And so they may be a more promising treatment, certainly for acute insomnia and possibly for chronic insomnia. One of the other things that was alluded to by Dr. Kaufman was the accessibility of Cbti, developing new modes of treatment and modes that are available to a broader public in terms of internet-based interventions. My own work recently shows that we can deliver Cbti by plain old landline in 20-minute doses, and we get the same strong effects as you do when you see classically delivered Cbti by face-to-face for an hour. And everybody's got even people without cell phones have landlines, and cell phones can act like landlines. So we did this without face-to-face, it was just voice-to-voice. And there are lots of these variations on theme going on that are going to make Cbti, I think, in one flavor or another, much more accessible to the general population. Whether insurance pays for it or not is another story.
Yeah, I was going to add that. So I was going to mention that there's one digital platform, I probably shouldn't mention the name, I don't know, but was recently approved by the Food and Drug Administration for the treatment of insomnia. And so hopefully that will pave the way for insurance companies to be able to start covering this intervention. The access and the insurance coverage have both been barriers to sort of adopting this more widely, despite the recommendations that this should be the first-line treatment. So we hope to see progress in this area.
Yeah. And there has been some of that at a national level. The VA has been remarkably foresightful in terms of their recognition of treating sleep problems in their population. And they have taken up Cbti with a will, and it is now available in just about all their centers.
Great. What about a focus on patient-centered outcomes? I think Dr. Stone does some work in that area.
Right. So I mentioned a little bit earlier, I think this is really one of the gaps, particularly in randomized trials of insomnia therapies, is that there's been, the focus has been entirely on sleep, but we know that sleep impacts a variety of other outcomes that are both, sort of immediate next day consequences as well as long-term. There has been less attention focused the most to patients. There's a new institute called the Patient-Centered Outcomes Research Institute that funds sort of comparative effectiveness randomized trials to try and determine what outcomes are really important to patients and how various established interventions for conditions like insomnia impact those sorts of outcomes. We know with insomnia, based on some of the surveys that we've conducted in my group, that some of those concerns related to insomnia include things like pain, like risk of falls, and like mood is a big one. But you know, I just wanted to emphasize that it's important to really focus on patient-centered outcomes and what is motivating the patient to come and seek treatment for their insomnia to begin with. Likely it's not only due to their sleep, but could include a variety of concerns that they have and downstream effects.
You know, one of the it seems silly to phrase it this way, but one of the nice things about insomnia is it is very patient-centered in and of itself, the disorder. And I mean that because how we diagnose insomnia is by patient complaint. It is totally by complaint. And that complaint has to involve both a nighttime component and a daytime component, or it's not going to be a diagnosable insomnia. And so we're already in extremely patient-centered territory because we're doing things that they are sensitive to. It may not have been framed that way originally when they came in, but ultimately they recognize how they sleep and they're happy or not happy about it. And they recognize how their daytime function is and they're happy or not happy about it. And so that's the essence of, if you will, of patient-centered, knowing, treating the patient in a way that they get the outcome they want. Also, how we evaluate insomnia and treatment outcome is principally by questionnaires based on patient response. So it speaks to that domain. It's not, I wouldn't say it's a no-brainer, but I think we're already operating in a good area in terms of treating patients as patients would be treated.
One other thing that occurs to me when we're talking about emerging therapies, I sit in the School of Public Health, and one of the issues, so we're thinking about populations and not just clinical populations. And there was a study that was done some time ago that looked at, just as an example, potential emerging therapy. And this has yet to be studied. It hasn't been studied close to as rigorously as the therapies that we've been discussing, the behavioral therapies. But there was a study done by Black et al. I believe it was 2015, and they looked at mindfulness in older adults, a mindfulness intervention. They did a randomized trial looking at the effect of mindfulness on insomnia in people who didn't necessarily have a clinical insomnia diagnosis, but they had a significant sleep complaint based on the Pittsburgh Sleep Quality Index. And they showed that this was quite effective. I like to think about, there's clinical insomnia, and there is the general sleep complaints that older adults experience that account for a much greater proportion of the complaining, the dissatisfied patients or individuals who aren't even necessarily seen as patients. So I like to think about ways that we might intervene at a population level to improve sleep. And that's something I've been giving some thought to. I loved that randomized trial of a mindfulness intervention that could be scaled up at a senior center level to improve sleep in communities. And I don't think that this is something we can hang our hat on and say, oh yeah, this will work for the average person. Doesn't yet, but I think it's encouraging that people are thinking about these sorts of interventions. Another example, just very briefly, with climate change, we're dealing with temperatures that are rising around the world. That's not going to be good for sleep. We know we don't sleep as well when it's hot. Thinking about ways that we can improve our infrastructure to improve, to lower temperatures and improve sleep might be another way of moving forward. Just thinking beyond exactly what we're talking about here.
Yeah. Adam, you may want to give them just a quick thumbnail of what you mean by mindfulness. Not everybody may know.
Oh, I'm sorry. So mindfulness meditation is what I meant. So this is a practice that came to us, from the East and is involved in many different cultures include mindfulness meditation as a practice, and it's often a component of yogic practices, for example. Someone else want to say more about it?
I think it focuses, my understanding is it focuses on being in the present and not worrying about the future and not ruminating about the past.
Right, and being permissive about which thoughts arise and not trying to control the thoughts, but paying attention to them. And really, it's about awareness of what's happening at this moment. But it is a practice. It's a practice that is formal and needs to be taught by an instructor so that it's done properly.
Yeah.
In recent years, there's been a variety of apps out there that have kind of brought this mindfulness approach to the masses, and it personally, for me, it's been quite effective in helping my sleep.
Yeah, just to amplify, when we were discussing cognitive behavioral therapy, I talked about relaxation components, and there's a strong overlap between relaxation training and mindfulness, or there can be. There's something, one of the things that I often suggest to people, because it's very basic, and is deep breathing exercises. Deep breathing exercises take into account mindfulness in terms of focusing your brain in the here and now, rather than on all your worries and anxieties or all your anticipated bad things. And they can be done before bed, they can be done in the middle of the night, they can be done before an interview if you're anxious. And it basically involves, I won't go into detail, but it basically involves focused deep breathing, rhythmic, slow, and paying attention to your breathing and not to the external world. This has two advantages. One is it focuses your mind so that your mind is not focusing on anxiety-provoking stimuli, but also it triggers your body's own physiological responses so that your autonomic nervous system shifts from the sympathetic side, where it's the fight or flight side of the house, to the parasympathetic side, where it's slow, restful, quiet. And this can be very, very impactful. And very often deep breathing is involved in some of these mindfulness treatments. In a nutshell, if any of you are interested in this, because I think it's very useful, the best way to find it is to Google Benson relaxation response. Benson westernized this Eastern phenomenon, and it's encapsulated in some of his work.
Thanks for sharing those great resources. So I know we touched before on a connection between the development of Alzheimer's disease and sleep disturbance. Any other new information we have about that, or is it just preliminary at this point?
Well, it's more than just preliminary. We actually think we understand the mechanism. It's a little bit complex, but let's say that one of the principal symptoms of Alzheimer's disease is the brain's inability to clear out certain waste proteins from the brain cells, from the neurons. And they're called tau and amyloid. Just think of them as residual garbage from brain metabolism. And like anything else, a neuron, a brain cell, is a machine that generates energy and produces waste products. And if those waste products aren't cleared, it can gum up the works. Well, just so happens that your brain takes that into account. You have a system that conduct by the fluid and the fat cells surrounding the neurons, it can extract that waste product. In Alzheimer's disease, we see tremendous accumulation of those waste products. We've now learned that sleep is permissive of clearing those waste products. So during sleep, the physiological system, it's called the glymphatic system, actually. You've got a circulatory system, you have a glymphatic system with fluids surrounding the neurons that pull those proteins out and take them away. If you disturb sleep, you compromise that system and you don't get clearage. So over time, there's accumulation of these waste products, and the current model suggests that over time with repeatedly disturbed sleep, you get increased accumulation of these proteins, and it puts you either at greater risk or exacerbates dementing-like symptoms. So the idea would be improve sleep in these people earlier on, maintain that improved sleep, and you increase the likelihood of clearing the waste products and therefore decreasing risk of developing the disorder.
That's very interesting. Thank you for sharing that that research with us, Dr. Vitiello.
Not much, but it's good. It's very exciting stuff. I mean, it really is. It shows, in all honesty, I did work on Alzheimer's sleep relationships back in the 1980s. And so it's really nice that it's finally come around where there's a link where we were exploring the association, just, disturbed sleep versus cognitive impairment in Alzheimer's. Now there's a direct physiological link that may indeed explain this relationship.
Well, family members who have a relative with Alzheimer's disease often ask me, what they can do to try to stave off things for themselves because they're worried about, a genetic component. And we talk a lot about brain health, and we talk about physical activity. And so now I'll make sure I'm integrating, sleep into that discussion as well. So thank you.
Yeah, and it's the double whammy, right? We talked about caregivers earlier today, right at the beginning, and this is a major risk factor. I mean, if you're a caregiver, you know that your sleep very often can be as worse as the person you're giving care to. And so it's really important whenever possible to try and ameliorate that impact and to try and sleep the best quality sleep one can, because it's going to maintain your health and you'll ultimately be a better caregiver.
Well, this has been a great way to spend the past hour. So thank you all to the wonderful members of the panel. And just for our audience, the other programs that we have include a webinar, Chronic Insomnia in Older Adults, Epidemiology and Approaches to Assessment in the Primary Care Setting, and also a podcast, Successful Conversations with Older Adults About Sleep Disturbances. And both of those can be found at the GSA website. GSA has an interest group. So if you just go to join GSA interest group and look for sleep, circadian rhythms, and aging, and we encourage members to join for additional information on GSA activities and activities of your colleagues. Thank you all for attending this momentum discussion, Sleep and Aging, Research and Treatment Implications.